Hysterectomies are offered in a very flippant way. So people are told things like, you don't need it anymore, we might as well just take it out. So if there's something wrong, meaning if we have heavy bleeding or fibroids or we are experiencing prolapse, then if we remove it, then problem is solved. And it's offered like, how could you even think twice about this? It's so easy, I'll just take it out. They're performed all the time.
All right. Well, it's a real pleasure to have Kim Vopni on again for a second time. Welcome.
Nice to be back. Thank you for having me again.
I'll have to have a link to the show in the show notes for our first episode because we covered pelvic health pretty in depth and vaginal prolapse and things that I've never even heard before. And it was such a good episode, and we're long overdue for another one. And I've been wanting to talk about hysterectomies for a while. And I love your podcast, Between Two Lips. And I think you've got some pretty good episodes all on hysterectomies. And because in menopause, at this age, we tend to have more and more women getting hysterectomies, and then they're all confused on hormone therapy and the menopause experience. So would love to pick your brain on everything we need to know about hysterectomies. So perhaps we should just first start with what is a hysterectomy.
Mm-hmm. So the term hysterectomy is removal of the uterus, but what gets sort of lost in translation is there are often other parts that are removed. And so there's a radical hysterectomy, which is removing everything. There's a partial hysterectomy. These are ovaries and the cervix. There's a little bit different terminology, supracervical, again, leaving the cervix. So it can be confusing because we don't know to ask a bunch of different questions of what kind of hysterectomy, what is staying, what is going. But ultimately, a hysterectomy is the removal of the uterus. And that can happen in many different ways as well, which also will complicate things.
It all sounds radical. Like when I first heard this, I was just like, they're removing a body part. And I mean, do we really need to do this? It's anything you want to remove, including me, and moving my femur for replacement is scary. You don't want to lose your parts unless you really need to. And I guess some women really need to. And so what are some of the reasons why a woman would get this diagnosis and be told that you need a hysterectomy?
The top three reasons are fibroids, heavy bleeding, and pelvic organ prolapse. And those are really, in the grand scheme of things, benign conditions, meaning not necessarily life-threatening. Sure, heavy bleeding could potentially lead down the path, but the other reasons would be cancers. So those would be the non-benign. Those are life-threatening, and so we wouldn't necessarily have a choice. But the 9 out of 10 hysterectomies are for benign conditions. And the majority, like 600,000 hysterectomies are performed in the US alone every single year. Again, most for benign conditions. And nobody is really educated about the procedure, about root causes, about what are the other options. What if I do have it? What are the implications going forward? So I feel like a lot of people put down the path of, just have a hysterectomy. Let's just take that out. We'll solve this problem by this, without that root cause investigation. Why are you heavy bleeding? Why do you have a prolapse? Can we do something to mitigate the fibroids? And in many cases, I think, we could prevent a lot of the hysterectomies that are performed if we had that root cause investigation.
How much time in advance do people need? Because are some of these, let's say it's fibroids, or if they're heavy bleeding, how long does it take before they can actually, say, shrink a fibroid, or so it's not bothersome anymore?
That's really difficult to say. I mean, I think things like heavy bleeding, you can, if you get to the root cause and if you are able to intervene with things like hormone therapy and diet and stress reduction, all the lifestyle things that we talk about, I think that change can happen really pretty quickly within a few months, I would say. With prolapse, I would say I myself had a stage 2 uterine prolapse that I was able to reverse with exercise. It was about 3-ish months for me. And that was with specific exercise techniques and doing all the things. And Not to say that's the case for everybody. It could be 6 months. I usually tell people who are dealing with heavy bleeding, fibroids, prolapse, give yourself at least 6 months of trying all of the different things and see what happens. And if you've given it a good college try and you've tried all the therapies, you've done all the work, you've been very consistent, been very diligent, if it's still, the symptoms are still interfering with the quality of your life, then we look at the surgical intervention. That also then is still then becoming an informed choice, knowing the repercussions of this surgery. Are you prepared for those risks, knowing that, yes, it may solve this problem, but it could potentially lead to other challenges? So that's the conversation there. But I generally would recommend at least 6 months of trying other things.
You have a big community and helping a lot of women out there with many issues related to pelvic floor health. But let's pick out the ones with the hysterectomies. What are the percentage that you're just seeing in your own anecdotal experience have given the good college try and just say, I really need to do this?
I don't know that stat. I mean, a lot of people come to me when they've already had their hysterectomy. There's not that many people coming to me deciding if they should. Usually it's the people after the fact who are now dealing with those other repercussions, who are now coming and saying, I wish I'd known this before. So I don't see as many people. There's a few, but I don't think it's an accurate representation. I don't feel like there's that many people who yet know about the root cause investigation. So I see a lot of people on the other side.
Okay, we're going to change that. That has to be changed,
Yeah.
especially knowing if you can do something about it.
Yeah.
I honestly wish, I mean, for every disease out there or every problem, we tend to think, yeah, we should give it a good college try for other things. It's just sometimes so easy just to get the surgery. Well, I can relate it just with my hip. And I thought for almost a decade, I was in denial. I'm not going to do this. Like, I'm going to do all the lifestyle changes, but there was no guidance. There was no one like you, or if you go Google search, the advice is go lose weight. And I'm like, this is definitely not my problem. And so you just try everything. But if you know you can change and can avoid a surgery, why not try? And I really hope that women listening now who are considering it or have a parent who's there, or you're not sure what to do, get in touch with Kim Vopni right now, because you should be able to try at least, and then we'll have some new stats.
I see more of the people on the other side who have already gone through that and are now, and sometimes it's 10 years later, sometimes it's 20 years later, sometimes it's 2 years later, but they're there after the fact. And I think I still haven't seen a shift of this yet, but it's the hysterectomies are offered in a very flippant way. So people are told things like, you don't need it anymore, we might as well just take it out. So if there's something wrong, meaning if we have heavy bleeding or fibroids or we are experiencing prolapse, then if we remove it, then problem is solved. And it's offered like, how could you even think twice about this? It's so easy. I'll just take it out. They're performed all the time. And yes, when you're in that moment, I've been there in perimenopause, when you have excessive bleeding. I used to say I had murder scene periods. I needed to wear Depends almost to get through a flight, because even just from not being able to get out of my seat during the takeoff, I would be flooding my pads. And so I know that. And yes, offered a hysterectomy, that would have solved every problem. But I feel grateful for the information that I knew, knowing that there are implications from a pelvic health and overall health perspective, that I want to hang on to my uterus and I need to understand, why am I bleeding so heavily? So anyway, it's in that moment when you have been struggling for years, or when you even just doesn't even have to be years, but if you are struggling and that solution is presented to you, and especially in a flippant way, it's, yeah, please, just, I don't need it anymore, take it out. And nothing is ever communicated about the root cause or the implications, which I really want to change.
It sounds like a functional medicine perspective. The functional medicine doctor would go, okay, you're, I don't know, vitamin D deficient. Well, why, or what's going on, or why are you tired, or why are you not absorbing your vitamins, or why is your gut not working, or why is they keep digging deeper. And that just makes a lot of sense. Like, why are you bleeding so much, or why do you have fibroids or the prolapse? And if you can't get to the root cause, then, or causes,
Mm-hmm.
why not? You mentioned already a couple of times that there are some implications that aren't discussed when the doctor is suggesting this to you, and it sounds like a great solution. So, what are the risks? Well, versus the benefit. I guess the benefit is all quite clear, but what are the risks of having a hysterectomy?
Mm-hmm.
Or and side effects
Yeah,
as
and
well, not just the risk of the actual operation, right?
yeah, of course, there's risks inherently to any type of surgery, and I guess I also want to just be clear that there's no shame in people who have chosen a hysterectomy already or who still will after this choose a hysterectomy. I want to make that clear that it really can be a very positive thing. What I want to impart is me, yes, I'm biased to the pelvic floor, but the pelvic floor is very central to a lot of what we do in life. It's part of our continence, it's our organ support, it's our sexual response, it's our core control and stability, it's our balance. It's very important. And I argue that post any type of pelvic surgery, hysterectomy included, the need for avoiding constipation, doing pelvic floor exercise, seeing a pelvic floor physical therapist is even greater because of the change to the landscape, because of the hormonal shifts that are sometimes happen instantly, and also because of the scar tissue. Like, things change. And so it sounds like, oh, just take out the uterus and we're fine. And maybe the ovaries come out, maybe the cervix comes out. But the uterus and the cervix play a role in helping keep our vagina suspended. Our vagina is this tube, and at the top of that tube is the cervix and the uterus. And it's becoming a little bit more common now, where it used to be that they didn't resuspend the top of the vagina. And so there's as far as I have done in my research, kind of what I think is the gold standard, which is called the McCall's caldoplasty, which is the resuspension of the top of the vagina. So anybody who is maybe considering a hysterectomy, make sure you ask your surgeon, how are you resuspending the top of, or are you going to resuspend the top of my vagina? That's an important piece, because without that, there's a certain type of prolapse called a vaginal vault prolapse. So without the support of the cervix and the uterus, the top of the vagina not resuspended appropriately can start to sag down, or even the walls sort of collapse in on themselves. So that's a risk of hysterectomy.
That was the moment when you told me that in our last episode. I said, "Did you say your vagina literally falls out?" And
starts to collapse. Yeah.
That shocked me. It's
Yeah.
and it happened as evidently it happens to a lot of women, a lot more than we think.
Yeah. Yeah. It's very common. Prolapse, the general statistics of prolapse are 50% of women who've given birth. And if you are having a hysterectomy because of a prolapse, let's say a uterine prolapse, the risks of incontinence and other types of prolapse is even greater. So if the reason you're having a hysterectomy is because of prolapse, the increased risks of incontinence and prolapse are greater afterwards. But there are also people who
with vaginal births, or both vaginal and C-section births?
Both. A lot of people interpret a cesarean as pelvic floor protective, and it is to some degree. Your likelihood of prolapse is a little bit less, but not much. So there was one study that it was 80, if I remember correctly, 83% of women at 6 weeks postpartum have some degree of prolapse. 50% of that 83% is a stage 2 or greater. And that's both vaginal and cesarean birth. So statistically very high. Now, there is often some resolution of prolapse beyond that 6-week period, but the other stat is 50% of women who have given birth, again, vaginal or cesarean, will have some degree of prolapse. And so it's super, super common. It's actually more common than incontinence is statistically. And I find much more devastating. So again, if the vagina has not been resuspended, you're at risk of any other type of prolapse, but vaginal vault is one of them.
Can I ask you, with vaginal prolapse, somebody says, okay, it feels uncomfortable, but would it literally, is it dangerous? Like it can literally, I don't know, be a problem. And what is the problem of having a vaginal prolapse without being too naive?
It's not life-threatening, it's quality of life-threatening. You could argue it's life-threatening for the indirect reasons of stopping certain activities and moving and because of the prolapse. And I want to clarify terminology as well too, because sometimes people are told they have a vaginal prolapse, and it doesn't necessarily mean vaginal vault prolapse. So vaginal vault is where the walls of the vagina will start to collapse in on themselves. Most common post-hysterectomy. Somebody might be told they have a vaginal prolapse where the bladder is bulging into the front wall of the vagina, the anterior wall, and that could be called a front wall or anterior wall prolapse, or a cystocele, or a bladder prolapse. So it's no wonder this is such a underserved part. It's so confusing. So we are never given any information, but then once we are given some, we might be told we have a vaginal prolapse, and somebody might interpret that differently than what a bladder prolapse would be. Do you see what I'm saying? There's also a posterior wall prolapse. So that's where the rectum is bulging in the back wall, also called a rectocele. Then there is uterine prolapse, sometimes womb prolapse would be called. There's something called a erythrocele, which is where the urethra is prolapsing, or a enterocele, where the intestines start to come down. So there's a lot of different types of prolapse. And the term vaginal prolapse may be given to somebody, but we need to dig deeper. What actually is it? The bladder? Is it the uterus? Is it the rectum? Is it, you know what I mean?
So does this cause discomfort, vaginal incontinence, or discomfort during sex, or what else? What other activities of daily living are difficult when you have any of these cases?
Yeah. So symptomatology is like symptoms of prolapse can vary greatly, and somebody could have a prolapse and not have zero symptoms, and somebody could have a very advanced prolapse with no symptoms. Somebody could have an early stage prolapse with every symptom under the sun. Like symptoms don't indicate severity per se, but very common symptoms are back pain, sense of heaviness or pressure or fullness in the pelvis, especially as the day goes on. Some people may see or feel a bulge at the opening of the vagina. Some people may experience difficulty with insertion. So whether it's tampons for people who still have their menstrual cycle, penis, toys, fingers, anything being inserted, speculums could feel uncomfortable. Doesn't mean that it's necessarily painful, but they might have some sort of sensation of something being in the way, so to speak. People might sometimes, when they sit down, they feel like they're sitting on a ball or sitting on an egg. They might have difficulty starting the flow of urine. So especially in a bladder or uterine prolapse, the bladder, if it's bulging into the front wall, there's a little pocket almost where urine can get trapped. So it might make it difficult to completely empty or to actually start the flow, they might also have increased senses of urgency because of the pressure. Somebody who has a rectocele, so the rectum bulging in the back wall of the vagina, might have difficulty with pooping. So again, they have a little pocket where poop can get trapped. So they never feel like they empty completely. They might feel like they need to strain. And there are some devices and tools you can use. One's called the FemEase. There's another one called Relieve, which they're essentially inserted into the vagina, and you can push that bulge, if it's on the front wall or the back wall, out of the way to help with voiding. So there are some tools and things that people can use. To kind of go back to your question, prolapse is not life-threatening. It's very quality of life threatening. You don't ever have to have surgery per se. I mean, there might be the odd scenario where if it's, especially in a post-menopausal person with low estrogen, it could get to the point where there's a lot of abrasions and infection, and that can become dangerous. So I would say, yes, it could, but overall, no, it's not. Your bladder is not going to fall out of your body, like literally fall out. There could be a bulge, sometimes advanced prolapse. It can look almost like you have a scrotum outside of the opening of your vagina. That's kind of giving a visual to what it can look like.
So then, yeah, it's not life threatening. Obviously, quality of life counts. I mean, my hip, that it's not life threatening, but boy, quality of life counts a lot.
A
So
lot.
sometimes you need to fix this. So would fixing the vaginal, you said suspending the vaginal wall, avoid some of these issues, right? If you get it done, quote unquote, correctly.
Yeah, so there's different types of repairs of prolapse. So an anterior repair, like a prolapse, bladder prolapse or cystocele as it's called, or anterior wall prolapse, they make an incision and kind of push the bulge back and then sew up that incision. Same on the back wall. Uterine, again, you can have uterine suspension. So that's another thing for people to consider is if you have a more advanced uterine prolapse and you've tried all the things, and we'll talk about pessaries in a minute. If you've tried all the things and it still is, you still feel like you need some assistance, it doesn't have to be removal of the uterus. There are uterine suspension surgeries as well. And it's weighing pros and cons, it's tissue integrity, it's lots of things that we need to consider with that person. And that's between you and your surgeon to make those decisions. Your only option is not take out the uterus. There's other things you could be thinking about as well. So there's the uterine suspension, there's pessaries. Pessaries are like an orthotic for your pelvic floor. So they're devices of different shapes and sizes that are inserted into the vagina that many of them you basically fold like a taco. You insert it when they open up. They provide support to the walls of the vagina where those bulges are. From a cervix and uterus perspective, they provide almost like a bit of a shelf so that there's not as much descent or bulging into the vagina, which is usually what's creating the symptoms or challenges for people. So pessaries can really be life-changing for people.
Does that have to be replaced, or you do it once and it's there?
There's different types. Some are inserted and removed daily or as needed. There are some that can be inserted and left up for 2-3 months. Some people choose to have their care provider insert them, remove them, clean them, reinsert them. So it really, again, can depend on the type of pessary itself, but then also the person. It's not the easiest thing in the world if you're not super mobile or flexible, to insert and get them positioned into the right place. So a lot of people do like to have a care provider do that for them. There's some really cool advancements happening with 3D printing for pessaries. There's a couple of companies. There's 2 companies I know of in Canada they take ultrasound images, basically pelvic ultrasound, and they map out and 3D print a personalized pessary based on your anatomy, which I mean, that just makes so much sense because yes, the other pessaries are great and there's all sorts of different sizes and shapes, but they're fixed for one thing and we are all different. And so I'm really excited about those advancements. There's also a company in the US called REIA, REIA Health, and they have innovated in the pessary space. And they've come up with a silicone, it almost looks like a parachute in a way. So when you are in, and they have an applicator that helps, because some of the other pessaries, it's hard to get your fingers up in place. So this one actually comes with an applicator and makes the positioning of it much easier. And also the removal has it's almost like a little pull tab. And when you pull it, it actually collapses. So when it's out and open in the vagina, providing the support. And then when you pull it out, it collapses those down. So it makes for easier removal. So again, they're kind of just coming into market now. It will be by prescription only with REIA Health, but there's also a couple of over-the-counter options that are technically not designed for prolapse, but many of my clients, myself included, I use something called the Poise Impressa. So Poise is a pad company. They have a product called the Impressa, which looks like a tampon, and it's inserted like a tampon, but what comes out is a non-absorbable piece. It's different than what a tampon would look like. And it's a little bit more, I mean, square is not quite the right word, but it's a bit more rigid on the sides, so provides some support to the walls. So I have an early stage bladder prolapse that's not symptomatic, but I use it for when I lift really heavy. I've had uterine prolapse, I've had a rectocele, I've had a surgical repair of my rectocele. I also have a birth injury called a levator avulsion, which is part of my muscles are not attached anymore. So that's some surgeons are starting to offer some repairs for that, but it increases your risk of prolapse. So knowing my risk factors, I do use that for additional support when I'm lifting. Many of my clients use that. They use another one called the Revive Bladder Support. And those are all technically designed for stress urinary incontinence support. But a lot of people with early stage prolapse find that it does help alleviate their symptoms. But now with vaginal vault prolapse, some people do find relief from pessaries with a vaginal vault prolapse, but not as much because again, it's if the top of the vagina is not attached properly or well, there's even if we put something in, it could alleviate symptoms to some degree, but we still are lacking that apical support. So yeah. So anyway, that was a long tangent about pessaries.
Yeah, it was interesting. So why is it that you wear it only when you're lifting heavy? What's happening when you lift heavy?
Intra-abdominal pressure management. So intra-abdominal pressure is something that we all have. It's something it's part of our core control mechanisms and systems and things. I mean, standing up from a chair increases intra-abdominal pressure. So I don't want to impart that intra-abdominal pressure is bad by any means. But when we don't manage pressure well, then we could leak. We may have prolapse. We could get hernias. So optimizing the pelvic floor and your whole core system to manage pressure is important. And for me, again, knowing that I have that tear, like the muscles are, no matter how much exercise I do, there's always an inherent weakness in my floor because of two of the muscles are not attached. So that I've given birth vaginally twice. I'm post-menopause. I've had a surgical repair. So that will inherently weaken some of the tissues as well. So just knowing that, I just want to use every support mechanism I possibly can, especially during times where there will be, when you're heavy lifting, there is an increase in intra-abdominal pressure. And that's okay. And I do all the things to manage it well, but I just want that additional layer of support.
Actually, now that we're on this topic of maybe some exercise, there was a member in our community who asked, how can I do body weight squats if I have a prolapsed bladder? And I'm guessing perhaps maybe you have some tips for her.
What I would say is there's a technique called the hypopressive method, also called low pressure fitness. And it is really powerful for prolapse, and especially bladder and uterine prolapse. I know myself included, but many people I know have improved or reversed or at least managed their prolapse. So that's one thing I would recommend because it helps with the pressure management. It could potentially help improve the stage of that prolapse. But ultimately, squats are not bad. A lot of people are told, don't lift anything over 10 pounds. Don't do squats. Don't run. Don't jump. They get this whole list. I say it's not life-threatening, but if we think about people who are told not to lift, not to jump, no impact, then post-menopause, we know how much bone loss we're losing in that first, especially 5 years. Our cardiovascular disease risk, to me, that becomes life-threatening. If we're telling people to stop doing this beneficial activity for our bones and our muscles and our hearts and our brains, right?
Those were the things that I was told as well not to do when I was first diagnosed with osteoarthritis. I thought, it doesn't make any sense. If I just stop, then I'll probably have other problems.
Yeah. And we need to have proper form, yes. And we want to make sure that the pelvic floor is optimized so that it can withstand that movement. And especially if we're loading it. But so many people are told not to squat. And what do we have to do every day? Several times a day, we sit down in the toilet and we stand back up. And if we then stop squatting, that activity is going to become harder and harder. And by removing hard things, we make life activities of daily living harder. So we should be training hard so that life becomes easier, not the opposite, right? My recommendation is continue squatting, but make sure that your pelvic floor is optimized. So see a pelvic floor physical therapist, do pelvic floor, whole body pelvic floor muscle training. So learn how to incorporate your pelvic floor into a squat where usually you're inhaling as you lower down. That's where the pelvic floor lengthens. You exhale, activate the pelvic floor and stand back up. If you're lifting heavy, so people who are into more of the powerlifting style, there may be a different breath strategy where you might inhale at the top and keep that inhale all the way down and exhale part way up. Some people inhale, then exhale and activate and go down and come back up. So there's different strategies depending on the person, how they manage pressure, their symptoms. But bottom line, I would not say to that person, don't do squats or don't necessarily do them differently. Just make sure the pelvic floor is optimized and you use your breath to help manage.
Oh, good advice. So let's go back a little bit to the hysterectomies. And so you're seeing the people who post hysterectomy. And do you know more or less the percentage of women who do have some of these problems post hysterectomy?
In the last stats I was looking, it's anywhere between 10, 20-ish percent in there. It's not a huge number, but enough that we need to pay attention. So incontinence is one. And again, that could be from the scar tissue. It could be from the hormonal changes. It could be from maybe things that were happening all along the way, postural adaptations or muscular adaptations that have contributed to the symptoms that were then exacerbated by that. So that's one, the incontinence piece. And then the prolapse piece. And again, the recurrence, it's not a recurrence per se if you've taken the uterus out, but if there is an additional type of prolapse that's happening afterwards, it's somewhere in that 10, 20-ish percent from the studies that I've seen.
And what about the people who get it for the fibroids? Do they never come back? It's done, or
the fibroids would not come back. Yeah.
So they're good for the rest of their lives. But as I understand, when we go through menopause, at least as more and more post-menopause, the fibroids tend to shrink. Or did you hear that?
Yep. And again, so there's the hormonal piece in there. Sometimes even like when we go back to that conversation around functional medicine and root causes has that person had thyroid? Have they looked at their full thyroid panel? Have they looked at their hormone panel? Like all other blood work, and I'm not a functional medicine doctor, so I can't comment to all of them, but the population that I work with, and even going through my own perimenopause journey of heavy bleeding, I had a couple of ovarian cysts, and the more I learned about trying to figure out what was going on in my body, I did not know the term perimenopause at the time when I was going through all of that. So not knowing what the hell is happening, all the research I was doing, the links between the thyroid dysfunction and the hormonal dysregulation is so high. And so I always am recommending that women do get hormone testing in their fertile years and also get a full thyroid panel that includes the antibodies. So we're ruling out autoimmunity because both of those are very closely tied into fibroids and heavy bleeding. So again, root cause, I don't know the percentages specific to if you've had fibroids, if you've had a prolapse, if it was heavy bleeding. I don't know those percentages, but yeah, it's a whole within women's health. So women's health in and of itself is underserved. Pelvic health is a segment of that is grossly underserved. And then the hysterectomy piece within the pelvic piece is grossly underserved in terms of the amount of information that we deserve but don't get.
Let's go into the protocols that we can try to avoid a surgery. If we have a woman listening now and is thinking, I'll just give it the good old college try. What are some of the things that she can do to try to mitigate a surgery?
So regardless of the reason, it was something I recommend every single woman do. And I recommend you do it every single year, even if you have no symptoms, is to see a pelvic floor physical therapist. So that would be number one. After that, if you could work with a functional medicine doctor or a naturopathic doctor or somebody who is well-versed in women's health, well-versed in hormone health, hormone therapy, thyroid, all those types of things, I would be investigating all of that. Then what we can do from an exercise perspective, exercise is not going to change your fibroids. Exercise is not going to stop heavy bleeding. Exercise can help with prolapse, but even with heavy bleeding and fibroids, especially with fibroids, there is usually, especially if they are larger or heavier or a lot of them, it can influence how the muscles are functioning. So regardless of the reason, we want to make sure we have an optimally functioning pelvic floor, the group of muscles of the pelvic floor. So pelvic floor muscle training is, people think of Kegel exercises, and we have loads of evidence about the effectiveness of Kegels when they're done correctly and when they're done consistently. But most people have never been taught or evaluated for Kegels. They've just been told, or they just hear the word Kegel and they think, well, I think I'm doing them correctly. And then often they think they don't work because they're not actually doing them correctly. Most people are doing them incorrectly. But the limitation with Kegels is they don't train the pelvic floor dynamically. They're typically not often done in an upright position. Usually people are doing them seated or lying down. And we need to train the pelvic floor against gravity. We need to train it in a variety of different movements for it to be as resilient as we need it to be in life. Because symptoms like incontinence and organ prolapse are usually most symptomatic when we are maybe exercising, when we're standing up, when we've been walking for long periods of time, right? It's not while we're sitting on the couch or while we're sitting at a red light in traffic. So optimizing the pelvic floor with pelvic floor muscle training, and your pelvic floor physical therapist is your gold standard to make sure that you are contracting and lifting and letting go. So a Kegel really should be like a squeeze, a kind of a closure and a lift and then a release. Most people interpret a Kegel as a squeeze. And so they are often squeezing their inner thighs, squeezing their glutes, sometimes holding their breath and bearing down. They're not actually activating the pelvic floor. The pelvic floor doesn't work in isolation. It does work with the inner thighs. It does work with the glutes, but those other accessory muscles should not be the boss. The pelvic floor should be leading the way. Pelvic floor physical therapy will make sure that you're doing it correctly. If you don't have access, there are biofeedback devices. We also have our own biofeedback with our own fingers. If you have a partner who has fingers or a partner who has a penis, those are also ways that we could get the other person to tell us, do you feel a little bit of a hug? Do you feel a bit of a draw up? Do you feel it let go? And that totally can help works. Us.
Yeah, I've done that after our first episode. Yeah, I talked to my husband, and it works. I mean, when you put your mind to it, and it's a great feedback system. And then, like you said, your own fingers. And I guess if you really don't want to do that, the pelvic floor specialist is another person who I found surprisingly in this small town of Spain. I heard that there was one. I thought of you immediately, ran to her thinking maybe my hips are just totally, it's my pelvis. And while she said everything was fine, everything worked. But I could find one in this small town. I think a lot of people can find a pelvic floor specialist in many places. I really underestimated how many there actually were.
Yeah. It's
growing.
It is. I mean, I've been doing this for 20 years, and yes, it has definitely increased, but there still, I would say, is a shortage. Most people will have a wait list for a pelvic PT. It is such a valuable therapy, and people, they walk away and they say, how is it that I've lived for 45 or 65 or however many years in this body and I didn't know this? And it's really remarkable. So pelvic floor PT, consistent pelvic floor exercise, whole body pelvic floor exercise. I would recommend hypopressives, especially for things like fibroids. Again, it's the weight that can contribute to some of the heaviness and pressure feelings as well, even if there isn't any prolapse. And so sometimes what hypopressives does is it lifts, it reduces the pressure. And there's a ligament that attaches to the bladder called the urachus ligament. And it also, the other part of the ligament attaches to basically our belly button on the inside of our body. And when you do a hypopressive apnea, it's a breath hold, there's an inward upward motion of the abdominal wall, and that elevation of the belly button influences that ligament, which influences the position of the bladder and also the uterus, and can help kind of lift. So a lot of people who may experience heaviness from prolapse or fibroids, even heavy bleeding, because sometimes the uterus becomes a little bit enlarged, they notice a lot of relief from the heaviness when they do a hypopressive apnea. And again, over time, the body then will adapt to that as it does to anything that we're doing. So hypopressives, pelvic floor muscle training, vaginal estrogen if you're post-menopause or approaching. Sometimes people would start a bit earlier as well. Avoiding constipation.
Or estradiol, which one? Which do you?
Estradiol is more robust. So most research that I'm looking at is really the benefits are not to say that estradiol is not beneficial. I would say estradiol is most beneficial. So I generally recommend a vaginal estradiol.
Like a
Doesn't mean, again,
cream
that
or a
estriol will not
pessary.
do.
Or how does
It's
that?
up to the person. So a cream, the benefit of a cream is it can go internally and externally because the tissues, basically like clitoris to anus, we have tissues that would benefit from the cream in our labia as well. So the cream we can apply everywhere. If we use a tablet, the tablet is inserted and it helps inside, but not a lot of it will trickle to the external tissues. Same with the pessary. And this is, to clarify, this is not the same as the medical grade pessaries for prolapse support. This is a ring pessary that is inserted and left in for the delivery of estrogen. It is, some people notice a little bit of support for their prolapse, but not very much.
Have, have you heard of Dr. Annika Becka?
Yes, yeah, she's a good friend of mine.
She talks about DHEA and how that is, she prefers that to say estrogen in vaginal estrogen. And she says that's because you can penetrate all layers of the vaginal wall as opposed to, as I think we were discussing estriol. I don't think it was estradiol, but she was saying, yeah, it seemed to have with her patients a lot more effectiveness. Have you learned anything about that?
Yeah, I recommend her product all the time. It's great. And so vaginal DHEA helps with the conversion of estrogen and testosterone. And so it's non-hormonal, but it helps hormonally, I guess, if you can look at it that way. I think from a research perspective, especially from a UTI reduction perspective, I do recommend estrogen. Vaginal estrogen is typically used twice a week. I would recommend Julva, which is Dr. Quebecca's cream, on the nights that you're not using your estrogen. I think, again, we can benefit from all the things. I like estrogen. I wouldn't say that I would replace Julva completely, replace estrogen completely with Julva, but I think the two of them can absolutely work perfectly. So I use estrogen twice a week and then Julva on the other nights.
Oh, okay. So we got the hyperpressive, the pelvic floor exercises, the vaginal estrogen or with the DHEA or without, and anything else?
I want to talk about constipation because constipation is a major contributor to the development of prolapse in general and urinary incontinence as well. And so, especially the people who, if they have prolapse, we already know that the risk of incontinence and prolapse is greater post hysterectomy if the reason you had it is because of prolapse. And a lot of the reason why that person had prolapse in the first place was constipation. And so, if we haven't addressed the constipation, we are much more likely to experience other types of prolapse afterwards. And the most common type of prolapse post-hysterectomy is a rectocele. So that's where the rectum is bulging in the back wall of the vagina. Not to say, again, that's the only type, but that's the most common. Obviously, we can't have a uterine prolapse anymore. There's no uterus there, but rectoceles are the most common, especially if that person has already been struggling with constipation. The likelihood of that happening is higher. So when I start working with people, water consumption and constipation are we start there. We can do all the exercise in the world. We could address all the other things, but if we are not pooping well and we are not hydrated, we're always going to be one step forward, two steps back. So you have to get that under control for sure before you're undergoing any type of pelvic surgery.
Yeah, I think that's a big one in general for a good aging and longevity. I mean, this is so basic, and I'm surprised with how many women are actually okay being constipated.
I am not one of those people.
It's yeah,
I
it's
can't
amazing.
function in a day if the most important part of my day is poop. I need to poop.
This is in addition to these great tips in terms of trying to relieve whether it's fibroids or heavy bleeding or prolapse, managing the stress and getting good sleep, and all of these things are probably also have an influence now.
1,000%. You talk about this all the time. Many of the people who are listening will have heard this from you or from many other people, that we need the fundamentals of good sleep, proper hydration, proper nutrition, proper elimination, stress reduction. Those need to be fundamentals, because when we are, as I've already just explained, if we're not pooping well, that's going to increase urgency, frequency, and prolapse, especially prolapse symptoms, but even the development of prolapse. If we're not hydrated, we're also going to experience more urgency and more frequency. We're then also not going to poop very well. If we're not sleeping well, then that is going to heighten our symptoms of prolapse and incontinence as well. That's also then when we experience those symptoms, we start to feel stressed out because of those symptoms, and then that we get in the rest of the world and everything else is puts us on high alert. We start gripping. We're not relaxing the pelvic floor muscles. We feel more symptomatic. So we can feel stressed, which can create symptoms. Then we feel stressed because we have symptoms, and we kind of go in that loop there. So yeah, there's diet and lifestyle. We always come back to diet and lifestyle, and it sounds frustrating sometimes, but the fundamentals have to be in place first, and then we can start layering on the other things.
Are there any risk factors for hysterectomies, like smoking or drinking alcohol or any of these, age, I guess, and menopause probably are some of them, but are there any others?
Yeah, age, all of what you've just said. And the perimenopause phase, I don't actually know the statistic from an age, I should know this, but the categories of when people are most likely to. But just anecdotally in my community, most people have had a hysterectomy in I shouldn't say most, many people have had a hysterectomy in that perimenopause. That seems to be the time, again, because that's when fibroids are showing up. That's when heavy bleeding is starting. That's when prolapse is maybe showing up for the first time because we've now got some hormonal situations happening. And a lot of people then struggle with constipation, and we go down that path. So I would guess that the hysterectomies are most common in sort of that 45 to 55-ish zone, 60 maybe, somewhere in there, but I don't know that stat.
What are your thoughts on progesterone for heavy bleeding?
I think it's great. And I would, again, from a root cause perspective, I'm not a functional doctor, but I know from my research and from my own body that made a significant difference for me. And it's knowing what I know about perimenopause and the progesterone estrogen piece. Progesterone is the first one to start to go down from a hormone perspective. It's so common that it's low. So why is it low? Let's find out the reasons. And again, that's beyond my scope. But I know that makes a remarkable difference for so many people, not just for their heavy bleeding, but for many other, for their stress, for their sleep, for their anxiety, for their overall mood and sense of well-being. Progesterone, I think, is amazing. Bioidentical progesterone for sure. I started out with a cream and transitioned to, and I would say the capsule, I noticed more of a difference in my own body with the capsule as opposed to the cream. But yeah, I think that I wouldn't say that's necessarily has to be your first stop, but I think it absolutely has to be considered when you're doing your root cause investigation. Why are you heavy bleeding? Look at your hormones and check out what's happening with your progesterone.
Yeah, I always wonder why very often when women are giving the Mirena coil with the progestin, the artificial progesterone, I think, well, why wouldn't you just do progesterone? Right. And natural bioidentical progesterone. So I was just curious to see if in your community, because you are dealing with a lot of women who are heavy bleeding or these kind of issues, if they're actually using the progesterone and having some results.
Yeah. Yeah, they are. And so on the IUD piece, that is something that was offered, and it is offered often, and it was offered to me as well. And it was offered to me for years, and I didn't want it. I didn't want any, I was trying to work on my hormones. I didn't want anything else in there. I definitely didn't want anything that was more on the synthetic side. I didn't like the idea of having something in my body. And so I was doing a bunch of things. Bioidentical progesterone, as I mentioned, I was on the cream at that time, and it definitely made a difference. I changed my diet, which made a difference. But I was still, in the grand scheme of things, bleeding more heavily than I should have. And it got to the point in discussion with my naturopath that I said, it's not natural, I don't want it. And she said, it's also not natural to lose the amount of blood that you're losing. So I did. That was one of the things that I did. It really didn't make a big difference for me from a bleeding perspective. The one thing that made the biggest difference for me was removing alcohol. And I was not I had maybe a glass or two of wine a week, maybe. I was not a big drinker. And so I never even thought, like, I'd removed caffeine, I took out gluten, I took out dairy, took all the things. And I thought, it can't be the alcohol. And as soon as I stopped completely, it was everything totally normalized. It was shocking to me.
before I let you go, I do have one last question about a woman. If she decides, okay, I've tried it all, I need the surgery, what is the best way she can prepare for that surgery?
For me, from a surgical perspective, first, so do your research of finding the right surgeon. And I say, if you can also ask your pelvic floor physical therapist, because they see a lot of the people post-op, they will have seen the work, so to speak, of the surgeons. So I would ask for their opinion. Do your research and finding the best person. Make sure it's somebody that you trust. Come prepared with all of your questions about what are the alternatives. I always use the acronym BRAIN, which is usually used in pregnancy. So the benefits, the risks, the alternatives, the interventions. What if I do nothing? Use your brain and go through that acronym and ask all of the pertinent questions. Do all the things. And if you do decide that you need to have the surgery, then put your body in the best state possible. Optimize your sleep, reduce your stress, optimize your nutrition, reduce the inflammation. We want to train for our surgery. So ahead of time, we should be doing even more exercise because we're going to have a period of being sedentary. So we want to build up as much muscle mass as we possibly can to help offset that. Get our nutrition totally dialed in, hydration, focusing on on protein, on all of the micronutrients that we need. Set yourself up for that recovery. So your recovery team, prepare food ahead of time. Make sure you have your kind of recovery zone set up for what you need. Again, optimizing protein, optimizing your hydration, things like vitamin C. I did a whole podcast episode with a woman who talks all about the nutrition piece of surgical recovery, which was super interesting.
Give us that link too. I'd love to have that link in the show notes. Yeah, great.
Yeah. I'll send that to you. And I did when I had my pelvic surgery, I had a rectocele repair almost exactly 4 years ago now. And I documented my preparation and my recovery in my blog. So people can find that at vaginacoach.com/blog. And yeah, it was all about preparing, just like we prepare for a physical event. We have to prepare for this controlled trauma that we are undergoing and make sure that we are in the best state possible, muscle function wise, body health, tissue wise, inflammation, low inflammation wise. Then in our recovery, a very intentional retraining, especially in this case of the pelvic floor, of that whole deep core system, working on our posture, avoiding constipation, and in a progressive path back to lifting. So it shouldn't be that, oh, you've had a hysterectomy, now you can't lift anything over 10 pounds or whatever, like a lot of people are told. Absolutely not. That is not how we build resilience and strength and capacity. There's no adaptation that's necessary. The adaptation that happens is we become weaker and we become more atrophied by sitting around not doing anything. So we need to build the foundation, rebuild the foundation, and then progressively load it.
Great advice. Wow, we did cover a lot. Thank you so much, Kim. I'm so grateful to you. I would love to direct people to your podcast, which I've learned so much from that. And you do such a fabulous job. It's called Between Two Lips. I'll have it in the show notes. And also the Buff Muff Challenge, which I did after our first interview. I totally loved it. It was a 28-day challenge. I finished it to the end. I love the community. The women there were so supportive. And I kid you not, this is, I don't know, 2 years ago, I still do the exercises. I imagine the blueberry, sucking it up, and then just gently dropping it down. It's still in my head. And I do your exercises as well when I'm doing my breath work. And I use it all the time. So it's been fabulous. And I highly recommend people to do it. And I've met so many women who have gone through this program already too. And they really love it. So I think it's wonderful. And I'll have that in the show notes as well. And you have a free book for us called The Inside Story. And the website, Instagram, Facebook, YouTube, I'll have links to that in the show notes. Before I let you go, is there anything else that you'd like to share when sort of like the most important thing a woman needs to know about hysterectomies?
Root cause investigation, and there's no shame if you've already had one or you do still choose or need to have one. Just make sure you are doing all of the work to support your core and pelvic floor afterwards for life.
Great. All right. Thank you so much, Kim, and have a wonderful day. And I got to have you on again sometime.
Would love to join you. Thanks so much.